Hello everyone, welcome to Medicine in Practice. We are going to talk about hypertension management in 2022. I'm Anagha, the Chief Editor of M3 India, and my guest today is Dr. Muruganathan. He is a proficient physician and practices in Coimbatore. He will be answering some of the most common yet very important questions on the topic of hypertension management. Welcome, Dr. Muruganathan.
Yes, good evening.
So I will straight head to the questions for today about management of hypertension. And my very first question to you, sir, would be if you could speak about quadruple paradox in hypertension management.
It's a very good question. In the management of hypertension, this is a real paradox. Very easy to diagnose hypertension, but often remains undetected. Very simple to treat, but often remains untreated. Despite availability of lot of new drugs and potent drugs, the treatment with all is ineffective. In spite of incidence, morbidity, mortality more than diabetes, we have very few people who are hypertension specialists than the diabetes. So these are the four quadruple paradox in management of hypertension.
Lovely, sir. So my second question is again a very basic question, sir, but I think it will be important if you talk about it. What are the steps to take accurate BP measurement here?
Accurate BP measurement is the key in management of hypertension, because in day-to-day practice, many of us, may not take the blood pressure. Only the staff nurse or the paramedical take blood pressure. Sometimes the inaccurate BP measurement leads to inaccurate treatment. So before a patient comes to you, they should have no smoking, no coffee or food or exercise 30 minutes before. They should be made to sit in a quiet room with back supported, with comfortable temperature, not with very big cooling AC. Before you take the blood pressure, 3 to 5 minutes rest. They should not have urge to pass urine, no talking, and they have to keep the arm rest. The heart BP monitor should be at the heart level. The feet should be on the floor. And more important is they should have a validated BP monitor, the cuff size which should fit the person. So if you do all these observations and if you take the blood pressure, that will be the accurate blood pressure measurement. And you should teach all the paramedicals and nurses to do this same.
Right. Thank you, sir. Thank you for brushing on those basics before we move on to further questions. So now, sir, I come to the guidelines. So as per the various guidelines, what is the definition of BP and what is the BP goal?
There are lots of guidelines now come. Really, it is confusing. European guideline says the blood pressure definition 140 systolic, 90 diastolic. The American Heart Association says 130 systolic, 80 diastolic. The international guideline says 130 by 85. Recent 2021 WHO guideline says 140, 90. But whatever the guidelines and whatever the definition, the goal should be around 130, 80. 130 systolic and 80 diastolic. When the patient has got coronary artery disease, heart failure, CKD, diabetes, and the risk is more than 20%, is active, independent, tolerant, you can reduce the blood pressure of systolic to 130. In a post-stroke and low-risk people, non-independent, intolerant people, it can be 140. You should decide according to biological age rather than the chronological age. So that is how the threshold. So if you have a risk factor, better to reduce 130, 80. And if it's an elderly person, frail person, 140, 90. So it all depends on individualized with depending on the comorbidity with the risk factors, etc. So if you can achieve that target, that is the best target. 130, 80 around.
Thank you, sir. So I understand that lifestyle modification plays a huge part in blood pressure management, but without speaking about that, I'm going to jump to the drug treatment, sir. I would request you to talk about the lifestyle modification maybe towards the end of it. If you could talk to us about the initial drug treatment strategy for hypertension, that will be helpful.
There are antihypertensive class of drugs like ACE inhibitor, ARB, beta blocker, CCBs, calcium channel blocker, and diuretics. In fact, other countries like America and other places, they don't give beta blocker as a first line drug. But in India, we prefer beta blockers also first line drugs. So these first 5 groups of drugs, you must use it when there is no complication, there is no comorbidity. Above 55 years, we prefer to use diuretics and calcium channel blockers. Below 55 years, ACE and ARB. Again, it is a very important concept that you should always start with combination therapy, and also the drug which you are giving should be time at target. It should cover the 24 hours BP, and it should also reduce the BP variability.
Right. Thank you, sir. So, in that case, sir, are there any ideal antihypertensive drugs?
Very good. An ideal antihypertensive drug should reduce nighttime blood pressure, treat masked hypertension, keep more time in target range, and also 24-hour BP reduction, early morning surge to be reduced, nocturnal dipping to be encouraged, BP variability reduction should be less. So if a drug can produce all these effects, that is the ideal drug, and that should be also cost effective, and it should also can be given with other drugs without much side effects. So that is the ideal drug.
Right, sir. In that case, sir, do you recommend ambulatory monitoring?
Yes. For every hypertensive patient, ideally, if you can have an ambulatory blood pressure monitoring, we can detect nocturnal hypertension, early morning surge. But in our country, we cannot do ambulatory blood pressure monitoring for every person. So home blood pressure monitoring at least, can do and find out the BP variability, and you can rule out mass hypertension. You can rule out white coat hypertension.
Right. Thank you, sir. Moving on with the drug therapy, sir, what are there any advantages of doing combination therapy?
Nowadays, all the international guidelines recommend, even when you come for the first time, you start with combination therapy, because quicker achievement of the blood pressure goals when compared to monotherapy. It builds on the notion that most persons with hypertension require multiple agents to achieve target blood pressure, decreased emphasis on individual drug uptitration, fewer side effects as an agents tend to be used at lower doses than when used as a monotherapy. And when complementary agents are used, the potential mitigation of side effects of either or both. Potential for synergetic and additive effects for overall improved blood pressure profile. If you are giving calcium channel blocker, you get pedal edema. If you are combined with ARB, that pedal edema is reduced. So like that, you can mitigate side effects also. The combination therapy is the order of the day. In 2022, people say single pill combination of 2 drugs, even 3 drugs, they say.
Right, sir. Well, it will be again helpful, sir, if you tell us how to choose a pharmacological agent for hypertension.
Whenever you come across any blood pressure patient, first thing you must rule out, is there any secondary cause? If there is any secondary cause of hypertension, that is a curable form of hypertension. I'm not talking about secondary hypertension. I'm coming to the primary hypertension. If it is simple hypertension, I told you 5 class of drugs, already told you. You can choose according to the situation. If there is no contraindication, there is no risk factors, no comorbidity, you can always start either one of them or 2 of them on the 5 drugs which I said: ACE, ARB, calcium channel blocker, diuretic, and beta blocker. In a case of risk factor, for example, if they have associated risk factors, or if they have target organ damage or complications, or if they have concomitant diseases or comorbidity, the treatment varies.
Right. So that brings me to the next question, sir. Then what are the drugs for diabetic hypertension?
In a diabetic hypertension, you must first check the blood pressure and confirm that it is diabetic hypertension. And once they have diabetic hypertension, you also check the urine for albumin. If there is no albuminuria, you can start them with ACE or ARB. Even if there is albuminuria, you start with ACE and ARB. And if BP is not under control, you add calcium channel blocker. And if there is still BP not controlled, you can add diuretics. And then if still in India, if they have any cardiovascular problems, and if the heart rate is more, you can add beta blocker like carvedilol. Suppose if the diabetic hypertensive patient has got coronary artery disease and heart failure or LV dysfunction, even in the first visit, Along with ACE in ARB, you should start carvedilol or beta blocker. Then you add calcium channel blocker. If still not under control, you can add alpha blocker. So this is how the algorithm for diabetic hypertension.
Okay. But sir, then on the other end of the spectrum is, let's say, maybe COPD. How about hypertension with COPD? How do we manage that?
Normally in a COPD, we normally don't use beta blockers. But sometimes when COPD is associated with heart problem, then you'll have to definitely use beta blocker. Usually in a COPD, hypertension is associated, most frequent comorbidity. So BP should be treated to the target, as I said, less than 130/80. Calcium channel blocker, ARB can be given. If there is a indication like cardiac problem, compelling indication, the best beta blocker which you can use, bisoprolol, nebivolol.
And then, sir, how about a smoker? For a smoker, what will be the ideal drug?
See, in the smoker, definitely beta blockers may not be good. So you have to give calcium channel blocker or ARB. So the benefits of treating smokers with beta blockers remain uncertain in the absence of specific conditions like angina or post-MI. When there is a spastic angina and things like that, we tend to use nebivolol. But our first line drug will be calcium channel blocker and smoking. Before that, what we advise, please stop smoking. That's the best treatment, and then give the treat drugs.
Right. Sir, is sexual dysfunction, or let me be more specific, erectile dysfunction common with patients having hypertension? And if yes, then does the treatment vary?
So in a erectile dysfunction, most of the patients will do better. Erectile dysfunction with hypertension, calcium channel blocker, ACE inhibitor, ARB, especially the valsartan. Not all ARBs. Valsartan is supposed to be good for blood pressure with erectile dysfunction. That is why in younger people, we normally don't give beta blocker, because beta blockers supposed to be not indicated, like atenolol, metoprolol, propranolol, and thiazide diuretics are not indicated. In case if the patient with erectile dysfunction also has cardiac problem, a compelling indication, then we use bisoprolol and nebivolol as a drug for reducing blood pressure, as well as reducing the cardiac problem. These drugs do not affect the erectile dysfunction, so that we can do this. These are the drugs.
Lovely, sir. I thank you very much. You have covered a range of topics in hypertension. I would like you to speak about lifestyle modification also, because that also is an important part of hypertension management. What is the advice that a physician should definitely give to his patient with hypertension?
Yeah, and so before that, also one more thing which I must mention: when the hypertension patient has got hypertension-mediated organ damage, like left ventricular hypertrophy, there ACE and ARB will be good. Indapamide can be given, and it's, suppose they have got heart problem, coronary artery disease, beta blockers, especially metoprolol and carvedilol, bisoprolol can be given. Okay, coming back to your question of the lifestyle modification. Many a time we always think about lifestyle modification, we say reduce the, increase the physical activity, DAS eating plan, that is dietary approach to stop hypertension, where you get consumed diet rich in fruits, vegetables, and low fat and dairy products, and salt restriction 2.4 gram per day. Also, alcohol to be reduced, weight loss to be maintained, stress reduction, and tobacco cessations are the important lifestyle modifications. But one important thing which we always forget is sleep. You should sleep well. De-stress and sleep well, because many of us, we don't talk about sleep. You should have a good sleep, 7 hours of sleep. That makes you little calm, and the blood pressure is definitely reduced. When you are obese, reduce your weight. Focus on the nutrition. Healthy lifestyle choices delay or prevent the onset of high BP, and also can reduce cardiovascular disease. So healthy lifestyle, 3 things: 1, it can prevent; 2, it delay the onset, and also reduce the cardiovascular risk. Eating a diet that is rich in whole grains, fruits, vegetables, polyunsaturated fats, dairy products, and reducing food high in sugar, saturated fat, trans fat, Very good. So DASH diet, I already said. Increase intake of vegetables high in nitrates known to reduce, such as leafy vegetables and beetroot. Other beneficial foods and nutrition include those high in magnesium, calcium, and potassium, such as avocados, nuts, seeds, legumes, and tofu.
Sir, any comment on coconut water?
Coconut water can be taken only thing when you are taking some diuretics. And if you think of electrolyte imbalance, you must always check the monitor potassium, because if you take too much of coconut water, there'll be chance of hyperkalemia. So whenever you are taking ACE or ARB or diuretic, you should monitor the serum potassium. So the management always, before you manage, you must overall assess the person with the clinical history, very good clinical history, good examination to rule out secondary hypertension, and do the basic tests like ECG, echo, and find out whether this patient comes under a very simple hypertension or say hypertension with HMOD, hypertension mediated organ damage, or any comorbidity, any risk factor. All that you assess and then tell the patient. Most likely, if the patient is educated, you tell them, teach them home blood pressure monitor and give them home blood pressure monitor, and that will make the patient empower in the treatment. He involves himself in the treatment. So he'll periodically come to the doctor with the blood pressure reading. It helps the doctors to find out whether the drug is working, whether there is any weak coat hypertension, etc. So number two, make the patient understand this is lifelong treatment. Many people, they take treatment for 1 year. Even educated people, they stop the treatment. So my message is very clear. When the patient is hypertension, you should be always under the care. You must check the blood pressure, monitor the blood pressure. Maybe you can reduce the dose of some drugs if you are very much following all the lifestyle modifications. Otherwise, this treatment is lifelong. Hypertension is a silent killer. So people may not have any symptoms in the early stage. They may have problems without your knowledge. Suddenly, they come out with nose bleeding. Suddenly, they may come out with blindness, kidney failure, heart attack, paralysis. So that is why hypertension is a dangerous disease, as a silent killer. So everybody must be aware. The awareness and the screening methods in India and in our country should be improved so that we can really get the hypertension patients under treatment. 1 in 4 has hypertension, and above 50 years, even 1 in 3 they get hypertension. So hypertension awareness and screening must be there. And for all that, you should have a very good lifestyle modification, salt reduction, smoking cessation, and good sleep, and then periodical monitoring and checkup. And one BP monitor at home will check for all the 4 persons or 5 persons in the house, which will go a long way to control hypertension and can make hypertension-free India, hypertension-free world. Thank you.
Sir, since you mentioned home monitoring, what is your opinion about the digital monitors?
There is a myth. You asked a question. There is a myth about home BP monitor. People think home BP monitor is not measuring accurately. The days are gone. Now there are a lot of validated BP monitors. Even in the international guidelines and research, they get automated BP monitor. They do very good machines are there. So buy a validated BP monitor and train the patients and patient attendants so that they know how to measure accurately. The first question I answered you, that how to measure accurately.
Yes,
when you follow those things and the blood pressure measurement is accurately measured, normally what we advise in home BP monitor also, first time when we give to a patient, we ask them to measure morning 2 times, evening 2 times, and take the average, or 3 times, take the average. Before, just after bed, after getting a bed, maybe before breakfast, before taking tablets, they should check the pressure. At night time, before going to bed, before going to table, take the tablets, they should check. 7 days, they should have to check. At least 1 day, first day they can leave. All the 6 days, average blood pressure, if the person has got more than 140/90, 140 systolic and 90 diastolic, that's a patient who is a hypertensive patient who needs monitoring, who needs drug treatment.
So would you like to name any machine?
Well, there is in the website, if you go, there are validated BP monitors available. There is MicroLife, there is Omron, there is a Point of Care. There are so many machines available. So you can go through the website. Validated BP monitors are available. Now, even the digital monitors in India, the ICMR is trying to certify certain monitors, which very cheap also and very good also. So digital monitors also available.
Right, right. Well, thank you, sir. That was a lovely roundup and very crisp pointers you have given with your vast body of work and your experience. You have answered a plethora of questions on hypertension management. Like you said, we look forward to more awareness, people being more aware about their conditions, physicians being in a better position to help people who are coming to them. And that's where M3 India comes in. Thank you very much, sir, for spending this time with us. And with that, we come to the end of this session.
Thank you so much. I wish all our listeners to follow the guidelines, the recommendations, and have a lifestyle modification, have a healthy, happy life, and a healthy, happy diet. Thank you very much. Good sleep is very important.